evening, those who are joining here and joining through the Facebook live stream. Please write your name, organization, and contact details in chat box. I'm Radha Paudel, author, activist, and founder for Global South Coalition for Dignified Menstruation. I'm speaking from Secretariat Office of Global South Coalition for Dignified Menstruation, based in Kathmandu, Nepal. The coalition is survivor-led global network for changing narratives around menstruation, from hygiene to dignity, and 5 days bleeding to life cycle approach. It is established in 2019, and now over 90 organizations are members from all around the globe. I encourage you all to get the membership. For details, you can find the membership form in our website, www.dignifiedmenstruation.org, and our social media outlets. As you are aware, Global South Coalition for Dignified Menstruation has been hosting webinars since beginning in various themes of dignified menstruation. Before starting the conversation, let me share the logistic. First, our speaker will present, and after that presentation, we'll have a question and answer. If you are watching through the Facebook page, please write your comments, questions in comment section. We will try to our best to respond. And if you are joining from here in Zoom, please write your questions or comments in chat box. Today we have a speaker all the way from USA. Just because of this webinar, she just wake up. Sorry, Lucy, for that. She is an independent consultant, Lucy Wilson. She has a broad skill set that she combines with the technical expertise in sexual and reproductive health and rights, including menstrual health. Her work often involves designing and implementing participatory, monitoring, evaluation, and learning approaches for complex initiatives. She also supports strategic planning and implementation, advocacy, and scaling the evidence-based practices. Based in North Carolina, USA, her business is Rising Outcomes. If you like to get more information about Lucy, you can Google Rising Outcomes. Thank you, Lucy, for your commitment. You are most welcome, and floor is yours.
Thank you, Radha, and give me a minute. I'm going to share my screen here so I can present. Let's do this one. So good morning, good afternoon, good evening, everyone. I assume it looks like my slides are up there. You can see them. Radha, can you confirm?
Yes.
Great. So thank you all for being here today. And I want to start by really expressing my gratitude to Radha for inviting me to join you all today, and for all of the work that she and you as members of the Global South Coalition for Dignified Menstruation are doing around the world. I had the pleasure of meeting Radha in Nepal in 2019 at the Reproductive Health Supplies Coalition meeting, where I gave an earlier version of the same presentation that I'll talk about today. This work was then published as an evidence review in 2021 in Sexual and Reproductive Health Matters. And if you're looking for any citations for things that I present here today, that paper is the best place to look. I've updated a few things since then, and I'll try to note those as they come up. So this is a topic that is very personal and important to me. For one thing, it has really helped me to better integrate my own personal life, my own decision-making and experiences into my professional work. I have long worked on the topic of contraception and family planning. And in that professional space, I rarely thought about how menstruation and contraception were linked. Though in my personal life, I had always made my own contraceptive decisions based on, among other things, my menstruation and how the different methods I might use would affect my menstruation. I started using a hormonal IUD almost 20 years ago, and I have not menstruated since. So I have never used a menstrual cup or a reusable pad or a cycle tracking app because those things were not yet mainstream 20 years ago when I last had a regular period. Not everyone who uses a hormonal IUD will stop menstruating as I have. Our bodies are all different and they are as individual as we are. But most people who use this method will have at least lighter periods. Despite that, I've worked on menstruation for the last decade, and I love menstruation as a topic. It's so important and so crucial to so many things: our reproduction, health, well-being, education, economic security, development, etc. But I have no desire to ever menstruate again. And I am grateful to have had that choice. Hormonal IUDs and other contraceptive methods can lighten the flow of menstrual blood and lessen pain, cramps, mood swings, and those other symptoms that we know happen with the menstrual cycle. These options for managing menstruation are not universally available, acceptable, or affordable around the world. And even if they were, not everyone would make the same choice that I have made. Some people prefer to experience their menstruation. I firmly believe that we should all get to make our own choices about how we manage our bodies, our reproduction, our sexuality, and our menstruation and most importantly, to have our own choices respected. So let's jump into the evidence around how menstrual health is related to sexual and reproductive health, not just in my own brain, but in the data and evidence. So it's framing here. In 2018, the Guttmacher-Lancet Commission on Sexual and Reproductive Health and Rights published a comprehensive, evidence-based, bold, and actionable agenda for SRHR priorities. In that, they outlined what was and should be in scope for SRHR. And while that definition was broad and holistic, including many of the things that you see here, did it address menstruation and helping women and others manage their menstrual health and the wider impacts of menstrual discrimination on SRHR? Yes, it did. It included one line on one page. There was 6 words out of a 43-page report. I'm going to make the case today that menstrual health should be a more significant part of SRHR, valued for more than just 6 words and 43 pages. So efforts to increase access to sexual and reproductive health and rights and to advance menstrual health are both focused on ensuring greater access to information, products, and services to support practices and behaviors that lead to improved health and well-being and greater gender equality. And as a reminder, menstruation at its core is a reproductive process. So this is a mini outline of what I'm going to discuss in the following slides. I'll start with the biological linkages and then go over social cultural linkages. And I want to note here that while there is evidence and data behind all of these linkages, it is not always robust. There are several areas where evidence may be limited, weak, and/or mixed. But with that caveat, let's jump in. So we start with the reproductive tract infections. And in 2013, a systematic review concluded that there is strong reason to believe that poor menstrual hygiene practices may cause RTIs. The authors note that several factors limited that conclusion, including a lack of standardized definitions for what good and bad menstrual hygiene practices were, as well as unclear causal pathways for the infections. In the decade since that review, there have been several additional studies, And what we're learning from those is that it is not so much the type of material that it is used to manage menstruation, whether disposable pads or cloth. That's not as important as that the material be clean, be dry, and be changed and cleaned frequently. In addition, a study among schoolgirls in Kenya found that the provision of menstrual products was associated with a lower prevalence of sexually transmitted infections or STIs. In this paper, the authors suggest that this protective measure may be a result of reducing the need for girls to engage in transactional sex to obtain their menstrual products. There are also several menstrual disorders that affect reproductive health. The prevalence of these disorders is much higher than you would probably think, mostly because they aren't commonly diagnosed. Many people believe that their period is supposed to be painful and heavy. But for menstruators with these disorders, that pain and bleeding is just worse, and sometimes really significantly worse. Dysmenorrhea, or painful periods, may affect up to 95% of women, with around 35% of women experiencing severe pain that regularly interrupts their daily activities. Menorrhagia, or heavy periods, is defined as more than 80 milligrams of blood loss per cycle. This affects about 30% of women, while some have much more significant blood loss. Menstruation can contribute to iron deficient anemia, and this is particularly so for the menstrual bleeding. Endometriosis is one potential underlying disorder to dysmenorrhea and menorrhagia, and it is thought to affect about 17% of women. All of these disorders lead to absenteeism from work and school. It impacts stress in relationships, which of course keeps women and girls behind in achieving gender equality. But all of these menstrual disorders can be successfully managed with hormonal contraception. In fact, the hormonal IUD has been shown to be the most cost-effective treatment for menorrhagia and may even be an effective treatment for anemia. There's a new paper out that's in the last year from Sheila Sinnaroy that's actually looked at menorrhagia rates in several countries, including in Nepal. So why are women using contraception? Unfortunately, I only have data on this from the United States, and it's quite old. I haven't seen this type of research replicated in any other country. But a review of data showed that about 14% of oral contraceptive users were using contraception only for non-contraceptive reasons, and about 58%, more than half, were using contraception at least partially for non-contraceptive reasons. And the most commonly cited non-contraceptive purposes was, of course, about menstruation, to alleviate menstrual pain and menstrual regulation. All of this leads us to the wonderful world of contraceptive-induced menstrual changes, or CMICs. And these changes can be seen as wonderful, but they can also be seen as miserable, depending on perspective. As I alluded to earlier, these CMICs are not super predictable. Different people will experience different changes. But in general, combined hormonal methods, those that use both an estrogen and a progestin, typically result in greater control and predictability of the menstrual cycle. While progestin-only methods typically start with spotting and irregular bleeding, but over time, the bleeding lessens. Copper IUDs, on the other hand, tend to result in heavier periods. What's important is that these changes are one of the most important reasons for non-use and discontinuation of contraception. But they're also seen by some people as a benefit or opportunity. So what affects that acceptability of these changes? There's many things. And while we have seen that the use of hormonal contraception to reduce, control, or even completely suppress menstruation has gained in popularity around the world, the acceptability still varies substantially across populations and also individuals. So among the many factors that contribute to a woman's willingness to tolerate these changes, I'm going to focus on the last two here. Attitudes and beliefs can include many things. An attitude can be a desire to menstruate because it makes you feel feminine or womanly, which is completely valid. Beliefs can include both true beliefs and false beliefs, such as myths and misconceptions. For instance, that amenorrhea allows bad or dirty blood to build up in the body, and that's not the case. Regarding experiences, contraceptive-induced menstrual changes affect women in the same ways that menstruation does, with both positive and negative impacts on daily life. These impacts may be more pronounced for those without adequate resources to manage the bleeding and other changes. In 2017, FHI 360 and PSI developed this tool to help explain these contraceptive-induced menstrual changes to those who are using contraception. It is called the normal tool and uses the letters of the word normal to describe how the changes are normal and can be seen as an opportunity. Usual menstrual patterns and fertility will return after stopping the method. Different methods have different effects. Even the absence of menses can be normal and does not necessarily mean that one is pregnant. Finally, if the menstrual changes are limiting an ability to engage in daily life, there are treatments possible. Cycle tracking, or keeping track of your menstrual cycle using a calendar, an app, a set of beads, or other tool, is a common practice and can help people prepare for their period to start or to anticipate or recognize symptoms of the menstrual cycle. It can be used if you're planning for pregnancy to time sexual intercourse, and it can also be used for contraception or to prevent pregnancy. There are evidence-based effective approaches to cycle tracking for contraception, and these are known as fertility awareness methods. They include the standard days method, which uses cycle beads, shown here on the slide, to track menstruation and to indicate when unprotected sex should be avoided. Then there is Natural Cycles, which is a digital app that uses cycle tracking and temperature tracking to know when unprotected sex should be avoided. Then the lactational amenorrhea method protects from pregnancy in the first 6 months postpartum if the parent has not yet resumed menstruation and is fully breastfeeding every 4 to 6 hours. So perimenopause and menopause are unfortunately neglected within both menstrual health and sexual and reproductive health. But the hormonal changes of perimenopause can result in side effects that are relevant to both menstrual health and sexual and reproductive health, including the changes in menstrual patterns. They may be more frequent or less predictable, and then vaginal dryness or discomfort during sexual intercourse. As someone who is now entering perimenopause, I'm fully understanding these linkages and changes in my personal life as well. It's important to remember that both perimenopausal and postmenopausal individuals continue to have sexual relations and thus continue to be at risk for sexually transmitted infections and gender-based violence. And even in perimenopause, individuals are still ovulating and able to get pregnant. Okay, so this is where we're going to pause and move over to the social cultural linkages between menstrual health and sexual health and rights. And much of what I'll cover in these next couple of slides is also discussed in the recent report from the Global South Coalition that was submitted to the Commission for the Elimination of Discrimination Against Women. And it was fun to read that this week and see the different places where this lines up. So how a child experiences puberty and menarche can affect future reproductive health. The start of menstruation marks a major change in a child's life. For some, menarche can be a moment of pride as she enters womanhood, but for others, it can lead to fear, shame, and isolation. And this latter is especially the case when children experience their first menstruation without any prior knowledge or understanding of what it is and how to manage it. Studies have shown that girls who were better prepared for menstruation had more positive feelings about it. And then there is some evidence, again, it's limited and complicated, but that negative feelings about menarche and menstruation contribute to a sense of a lack of bodily control, which translates into subsequent inability to negotiate safe sex and other reproductive health issues. So from that report from the Global South Coalition that I just mentioned, one of the things I picked up was that menstruators and non-menstruators begin internalizing menstrual discriminatory perceptions and practices from as early as 6 to 9 years old. The resulting gender stereotypes serve to maintain unequal power structures and systematic inequalities in a vicious cycle. Restrictive gender norms that discourage girls and women from leaving the house or interacting with men outside their family are present in many cultures and societies. And beliefs that menstruation is dirty or should be kept hidden contribute to these norms. And adherence to the restrictive norms may also be self-imposed as menstruators worry about their ability to contain menstrual leaks or odor. These restrictions may also be imposed paternalistically, seen by those implementing them as a means of protecting women and girls from sexual advances and harassment. But these restrictive gender norms are associated with longer-term SRHR outcomes, such as a lower likelihood to use contraception and a greater exposure to intimate partner violence. And then again, both menstrual health and sexual and reproductive health interventions aim to have women and girls engage more fully and on equal footing with boys and men in all spheres of life. Also from the report from the Global South Coalition for the Discrimination Against Women Commission, one of the things that I picked up was that the UN framework on gender-based violence identifies 4 categories of violence: sexual, physical, emotional, and then the deprivation of services. And many forms of menstrual discrimination touch on multiple of those categories at once. A couple of examples here. There is some evidence that adolescent girls engage in transactional sex, often unprotected, in order to obtain menstrual products or the funds to purchase them. For instance, one study in Kenya found that 2/3 of young women using commercial pads reported that they had received them from a sexual partner. In addition, given the taboos around menstruation and defecation, women may prefer to go to the toilet at night when the darkness provides some level of privacy. However, as wash facilities are often at a distance from residences, this places them at risk of harassment and sexual assault. Finally, education is a human right, and keeping all children in school is a shared objective of both menstrual health and sexual and reproductive health. Evidence shows that the longer a girl stays in school, the more likely she is to use contraception and condoms, the more likely she is to delay marriage and first birth, and to use prenatal care and have healthier babies. The effects of education are long-lasting. As you all probably know already, research on menstrual health interventions, however, have yielded mixed results in increasing school attendance. One potential reason for this discrepancy is that the girls leave school around menarche for various reasons, not all of which can be addressed by typical MH interventions. But that these reasons may still be linked to puberty and menstruation, such as pain, perceptions of increased vulnerability, and parental or cultural influences that discourage girls from attending school, especially when menstruating. So that wraps up the evidence that we identified for linking menstruation to sexual and reproductive health. I think there's some more areas for potential integration and potential evidence that could be built, and would love to talk a little bit more about those later on. But with that, Radha, I'll hand back to you to lead us through some questions and answers.
Thank you so much, Lucy, for your very clear, crystal, and comprehensive presentation. And also thank you for incorporating the principles of dignified menstruation from Global South Coalition. I really appreciate it. I do not see any questions yet. in Facebook comment section as well as the chat box. If any of you like to have any questions, please write here. If not, Lucy wanted to ask the few questions with me. So let's have a conversation, and then by the time we receive the questions in chat box, and we'll continue our conversation. We have 30 minutes, so enough time. Lucy, you said you wanted to ask the question with me about the SRHR. So I don't see any questions in the chat box. So
Do you want to start with that, with just us asking each other questions then? I think that sounds...
Yes, yeah.
So I'm always curious how, in different contexts, in different countries, and in different organizations and just ways of thinking, how well is menstrual health being incorporated into sexual and reproductive health and rights, in your opinion, from what you're seeing where you sit? So I would love to hear from you on how well you think that we're doing now, today, in 2025, and from others, I think on the line, on Facebook, on Zoom, if they have any thoughts about how things have progressed as far as integration, I'd love for them to add comments about that as well.
Okay, thank you. Can you stop your screen? So I also like to share my screen, and I think it will be more easier to understand. And then we will continue our conversation. Based on our experience, the menstrual discrimination, that means the silence, stigma, ignorance, taboos, restrictions, abuses, violence, and deprivation from services and resources that associate with the menstruation throughout the life cycle of the menstruators, we call menstrual discrimination. From that lens, we identified that the menstrual discrimination has been practicing across the globe, no matter whether it is global north or global south. However, there is not much research done in the area of the menstruation. Globally, the narratives made in a way that it was the issue of poor countries or global south or poverty or education. But it's not like that. Regarding to the menstrual discrimination, there is no extensive discussion down the line of 76 years of human rights history, and including the SRHR since 1994. These are the few examples. In Ghana, in Burundi, in Egypt, Bangladesh, Nepal, or Australia, UK, Canada, everywhere there are the certain types of menstrual discriminatory practices. Except silence, ignorance, the restrictions like not allowed to touch the water source or communal river, or not allowed to take a bath or cook, or the menstruators hesitate to do the regular work because of the fear of leaking. That kind of things we can see everywhere. And while the menstruators experiencing this kind of menstrual discriminatory practices, their dignity, their freedom, their equality, their right to food, right to health, right to educations, compromised in multiple ways. This is the example from Sri Lanka. Recently, Sri Lanka has done a very thorough research. We will be sharing that research finding by 18th March. I request everyone to follow us. But that report, this report, which is shown in the screen, is the compilation of the multiple workshops we had done in Sri Lanka in 22 and 23. Altogether, we identified 155 types of different menstrual practices. And if you go in the beginning, that related with the right to dignity, freedom, equality, participation, health, food, and water. See the ranges of the practices. We just copied from their newspaper to here. We don't do anything else. And related with the menstrual health issues, if we talk about the menstrual health, you can see the little number of the practices. And if we talk about the period poverty or products issue, and the list is really short. And if we talk about the WAS initiatives, the list is still short. And in addition to these, still there are other kind of discriminatory practices practicing in all kind of cultural setting in Sri Lanka. So through this slide, it is easier to conclude that if we talk about the menstrual health, we are missing the other forms of menstrual discrimination. If we are focusing only in the period poverty or the product, menstrual product or menstrual management, we miss the other kind of menstrual discriminatory practices. So the menstrual discrimination is very complex and multifaceted. And as you highlighted earlier, the menstrual discrimination learn or socialize between the age of 6 to 9 years. We had done lots of exercises with the participant, physical or virtual participant from USA, UK, Nepal, and in global platforms like Women Deliver, CSW, and other platforms. And we knew that between 6 to 9 years, the menstruators knew something about menstrual discriminatory practices. Since then, the menstruators started to think a little bit unsafe, unequal, or something different, something inferior. And when they have a first menstruation, because they have to follow additional layers of the menstruatory practices based on their context, and then their level of the confidence, freedom really go down. So this is how they consider themselves as a inferior, disadvantage. Whereas non-menstruators don't feel that kind of things because they socialized in a way that they never menstruate. They have a privilege. They have the power. So that kind of things is missing in a global discourse of menstrual movement. We only focus on the 5 days of the bleeding. We only focus on the SRHR issues like adolescent health, safe abortion, family planning. These are the important things, but we are missing the vital role of the menstrual discrimination in construction of the power, patriarchy, and creating systemic inequalities and multiple level of operation. The same idea, because of this role of the menstrual discrimination, the home is becoming unsafe. In other words, home is becoming the factory for the gender-based violence, domestic violence. No, somewhere we call the intimate partner violence or marital rape or sexual abuse or unequal property rights. No matter what kind of gender-based violence, but the home experience more, and the globally home is not safe place. Unfortunately, the UN do not include that kind of menstrual discriminatory practices, whereas it define the gender-based violence, sexual and gender-based violence means the emotional, physical, sexual and deprivation from services and resources. They define the 4 category of the gender-based violence, but they don't count the menstrual discriminatory practices while they publish the data. that I have already explained. One, menstrual discriminatory practices may fall more than two categories of the sexual and gender-based violence. For example, not allowed to cook at kitchen. It could be the physical, emotional deprivation from the resources, and if the menstruators try to do it, she may encounter with the other kinds of violences. So that kind of things we missed. Likewise, since 1948, we have been talking about human rights. 76 years history down the line, we don't consider seriously the menstrual discrimination is a violation of the human right. So menstrual discrimination is very complex, very multifaceted, and it impacts all aspects of the menstruators. And in a course of the SRHR, in a way that the menstruation is everywhere, we cannot move forward because I'm coming from the nursing background, public health nurse. We cannot provide or serve the family planning methods without having the history of the menstruation. But we will only ask the heavy flow or regularity or not, but we don't ask about the practices. We don't ask about the knowledge, understanding about the menstruation. So, as Lucy said earlier, only the 6 hours. While the SRHR discuss about the anatomy and physiology of the reproductive organs, that time the menstruation just pop up. And it simply says the process, biological process is technically defined like in nursing or medicine school. It doesn't say this is the pure blood, clean blood. It's not a disease condition. It's not the weakness. It has a certain condition where the menstruators may experience severe kind of menstrual practice symptoms, and the menopause. That kind of things are not discussed at all. And this is the findings of our baseline survey from Nepal. The full report is available in website under the publication sub-menu. The government has made available the services, SRHR services, even in the smallest unit of the health facility in the village, including the safe abortion service, medical abortion. But who are utilizing these services? The menstruators who cannot say no about menstrual discriminatory practices or who don't have an agency or bodily autonomy, how could she seek the safe abortion services, certified safe abortion services, or how could she say, I'm not ready, I don't like to have the unsafe sex? So there is a service, there is a policy, even Constitution guaranteed that, but there is a barrier within the person, within the family, within the community, school, and everywhere. That part is missing. And many of my friends claim that they have been doing excellent job comprehensive sexual education, and they include the menstruation. And based on the leadership of that organization or individual interest, some sort of dignified menstruation or menstrual health is incorporate. But principally, within the concept of the comprehensive sexual education, there is no about the menstrual discrimination or dignified menstruation. And likewise, as Lucy highlighted, Oh, because of not having the menstrual pad, the girls drop out from the schools. This is how we pretended. We come up with the research report too. But who is calculating that the menstruating girl in Ghana or Burundi or Sudan or Nepal or Bangladesh, they have to wake up early, at least 30 minutes early, because of hiding the menstruation and managing the menstrual blood. And she could not plan her fooding, dressing for get ready to the school. And she could not, she wouldn't have the confidence to sit in her regular place in classroom because she is scared from the leaking and the teaching. So she's looking the corner, the dark place, and wearing the double pads, double panty, double trousers, and wearing the long coat or sweaters or something to hide in case of the leaking. So the entire 24 hours for 5 days, her learning or educational cycle is interrupted. If we calculate 5 days multiplied by 12 months, that means 2 months in a year. Sometimes I wondering, our grandmothers, even my time, I use the literally cloth pad, long cloth pad, and I continued my school. The most important thing, whether we dismantle the discrimination or not, if we able to dismantle the menstrual discrimination at home, at school, our girls or our menstruators would have a confidence, and the non-menstruators would start to hold the accountability, and they start to teach and respect the menstruation because they born with the menstrual blood. So in the meantime, many scholars claim that, oh, we have been distributing the menstrual pad and we are working on SRHR, we are working on dignified menstruation. So to us, to Global South Coalition, we always like to see through the 3P approach. Whether these products are available based on the choice, right to choice, and while utilizing or using this menstrual product, whether the menstruators are free from free from any forms of menstrual discrimination or not. That is very, very important for us. And likewise, the second P refers to the planet. The menstrual product should not bother our planet, including the waste collector, and the pocket means should be available with the quality and standards. These kind of things are missing in our conversation. The child marriage, the school absenteeism keep coming in SRHR conversation, but the menstrual discrimination is one of the driving force for child marriage. It force or put in trap to the menstruators to get the child marriage. That kind of things, the global community, including ourselves, have to say more critically. And few friends are working tirelessly on the SDG, and all the time they talk the gender equality SDG 5 or clean water and sanitation. But for Global South Coalition, the dignified menstruation is a precondition for achieving SDG. How could we reduce the poverty or make zero hunger? In Ghana, the menstruators cannot touch the communal water or the not able to cook food or not able to eat the milk or pork in Argentina. So they're deprived from having nutritious food like vegetables, proteins, and other nutritious food 12 months in a year. And how could we prevent the anemia or other kind of diseases. So that's it from my side. This is the little bit critical kind of things we come up with, the learnings, sharings, and some researches. I saw the colleagues from Post Feministra. They have done research on menstrual discrimination across the 9 countries from Global South, and they would have a wonderful report. No matter about the religion or education or geography, everywhere the menstrual discriminatory practices are there. And because of the menstrual discriminatory practices, the SRHR services are hindering, and the access with the product also hindering. So it's the exploring and dismantling the menstrual discrimination is removing the underlying barriers and make the emancipate or build the agency and guaranteeing the bodily autonomy, and they can do everywhere. I was trying to write the journal article for Frontiers, because Frontiers is publishing one journal dedicated to SRHR and climate justice. And my colleagues wanted to submit the article, the interconnection between menstrual discrimination, SRHR, and the climate justice. And I know you since 2019, we have a informal communication in between, even though I missed out your research findings. And then, oh my goodness, you are the only one person who really acknowledges the de-association between SRHR and menstruation. Otherwise, everyone from the UN, big INGOs, the networks, they always say it and they don't like to listen us. And this is how I'm so inspired and like to have you for the conversation. And from this conversation, we cannot do everything, but we can appeal, and we also can unlearn by ourselves and sharing the learnings, and then we can move forward in a positive direction. Let me read out here. In Angola, menstrual health and menstruation worked as an entry point in 2020 to talk about SRHR and AP. Since culturally these were still sensitive topics that were not talked about public. Thank you very much, Anna, for sharing. So wonderful. Actually, for Global South Coalition, dignified menstruation is like an entrance for claiming or enjoying the entire SRHR, no matter whether it is safe abortion or family planning or adolescent health or any type of cancerous condition. Since menstruation is a natural process, how can discrimination on menstruation can be minimized? What is your role to minimize the discrimination? My dear Lucy, this is yours.
Okay. Thank you, Radha, and thanks for sharing all of your perspectives from the Global South Coalition on menstrual discrimination and SRHR. And I love how there is so much overlap, because I really think that if we look at the broad definition of these things, they are all inclusive. Yes. Sexual and reproductive health, the broad definition there is, and also with menstrual health, includes not only those physical elements, but the definition technically says physical health, emotional health, mental health, and social well-being. And so menstrual discrimination, dignified menstruation, to me is part of that. Just like if you think about dignified menstruation, it also includes all of the same things. So to me, they are, if you look at them broadly, they are all encompassing of each other. So as far as, I want to first touch on that menstrual health and menstruation more broadly can be this wonderful entry point for SRHR and family planning, for HIV. We've seen this in several countries, and I think it's a really great way to start thinking about how to integrate programs. In several countries, programs that have done this, that have offered menstrual health, they've found that that's really what people are first eager for. That's the first thing they want to come and get. They want to come and hear about menstruation and get a menstrual product and ask questions about why and what's happening to their bodies. And once they tackle the menstruation, then they're willing to say, okay, I trust you. Now let's talk about some of those more sexual and reproductive health topics like contraception or STI. So it is such a great entry point, and I hope that people who are designing programs for SRHR and for menstrual health think about that as an entry point to draw people into their programs.
Yes. Thank
And
you
I would
very
love to see, if there's things from your work in Angola, Anna, I would love to see if you could share some of that in the chat.
Yeah, please share the strategies or links, or if you have any comments, please feel free to share. In addition to Lucy, we cannot remove discrimination like taking a cetamol and then in 30 minutes reduce the temperature. It's not like that. We need to understand a couple of things. First, the menstrual discrimination is very much complex, multifaceted, and is interconnected with so many other themes. The menstrual discrimination in UK and menstrual discrimination in Nepal is totally different. But there is a discrimination. Somewhere visible, somewhere invisible. And another important thing, the global community, the UN, and other big organizations, donors, academia, is still not ready to put the menstrual discrimination as a priority to address, or missing fact in a history of human right or SRHR or child right or decades long decent work, not decades, century long intervention of decent work or child marriage intervention. So first, we all, wherever we are, we have to acknowledge the gravity of menstrual discrimination. And then whatever we can, whatever funding or expertise we have, let's keep talking. And that talk create the space. And then we can make, from this conversation, few people can change. Right now, after that session, they have already started to promise within themselves. Few may take 2-3 months, few may take to change for 2-3 years, and few may take like 20 years. But we should not wait for the 20 years. Oh, this is the generation things. Let's die our elders. No, let's keep talking. Let's keep talking wherever we are.
And I think talking is so much the key. I think the more that we talk about these topics, the more that we can break down the discrimination. And I think at some levels, just that initial talking, getting a little bit about menstruation into the media can really help break down some things. But you're right, it's also really complicated and multifaceted and can last for years and years and years. And I see that in myself. So I have an example from last year. So I've worked on menstruation for 10 years, worked on sexual and reproductive health and addressing stigma in these things for my 20 years of my career. And last year, one day I spent the entire day writing an article about addressing menstrual stigma. I spend my day thinking, menstrual stigma, how do we address it? And that evening I go to a friend's house. And as I'm leaving, I say to her husband, I haven't been sleeping well, so I need to go home and try to get an early night. And he said, why aren't you sleeping well? And I said, oh, I think it's just age. I think I'm just getting older. And he said, do you mean perimenopause? And I went, yes, I do. But I didn't want to say the word perimenopause to my friend's husband because it's stigma, right? And I just, hit myself on the head because I had spent the day thinking, how do we address stigma? We say these words out loud. We say menstruation out loud. We say perimenopause out loud, and that's how we address it. And so even I, last year, after spending a day thinking about it, failed my own advice and just said, I'm getting old. So it's so challenging, but we have to keep working at it every day, all of us.
Yeah, it's very powerful examples, and we have to start from ourselves. I see the message from Anna again. This was exactly the case in Angola. Let me share some of our experience. Let's have a private conversation. Please write to us, and let's have a Zoom meeting, and let's plan for the webinar, because we wanted to bring all voices and then create the synergies for dignified menstruation. And then I saw the friend Afi from Post Feminista. If you like to share your findings from 9 countries, let's have a plan. And we have only 4 minutes to go. Dear friends, please follow the conversation through the webinars. We have another conversation in March 7th. It is all about the dignified menstruation and mental health. And by March 18, we'll have a sharing of the research findings from Sri Lanka. It's a nationwide research. And then we have others in online. Please keep follow our social sites. And if you like to know more details about the dignified menstruation, the General Recommendation 41, which we submitted to the UN, or SIDA SADO report, or other reading materials or researches, please visit our website. We try to translate in multiple languages: English, French, Spanish, Nepali. And if any of you like to speak, or if any of you like to invite Lucy to have a conversation, please feel free to write us. The Global South Coalition is all doing for last 5 years, because we are very much committed to make this old dignified menstruation friendly at all levels, within the person, within the family, school, community, workplace, and parliament, and everywhere. So together we can make a difference. Thank you so much for your time and listening. Thank you so much, Lucy, for trusting us and agreeing to speak. It is not easy we are working in the 2 different, very different time zone. Right now here is about 7:30, and you may have the 8 or 8:15 in the morning. So even though it's a commitment matters.
Well, thank you. It's my pleasure to be here and to talk to you again, Radha. It's always good to see you and to be inspired by the work that you and the wider coalition are doing. So congratulations to you all and on all the hard work. I'm excited to see some of these findings that you've talked about, and that the report 41 to the CEDAW was really a great report. So thank you. I hope everyone takes a look at that.
Thank you so much, everyone. Sorry we did not provided the place to speak directly because the technical region. We will try our best to make more comfortable. Let's see. Thank you, and very good evening from Secretary Office of Global South Coalition, Kathmandu, Nepal. Have a good day, good night, good afternoon. Thank you, everyone.